This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Conception, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care, to me, means freedom, not only for the physician, but for also the patient. In a prior position, I was the chief medical officer of a primary care center with 24 physicians and 6 mid-levels. In this role, I was the person negotiating with the insurance companies for labs, imaging, clinic visit reimbursements. I quickly came to the conclusion there are what I call the 3 Ps in healthcare: the physician, the patient, and the payer. However, in the current fee-for-service model, only one of the 3 players wins. The other 2 always lose. In any other business model, for every winner would run you out of business. This frustration led me to look at other healthcare models, where as a physician, I could be happy providing medical care, but my customer also had the opportunity to be happier and healthier. In 2012, while attending an AAFP meeting, I was exposed to direct primary care by a couple young physicians in Wichita. Being an ex-banker, when financing a business, we knew for them to be successful, they needed 4 things. First, the product had to be something that people wanted and added value to their life. Secondly, the product needed to be easy to get or accessible. Third, the product had to be affordable. And finally, the product needed to be easy to use. In the healthcare industry, direct primary care is the only model that meets that criteria. In late 2016 and early 2017, when I was ready to get out of healthcare secondary to burnout, I got serious about TPC. And in the fall of 2017, at the ripe old age of 57, made the leap and opened Click Family Healthcare. I am Dr. John Jacobsen of Click Family Healthcare, and this is my DPC story.
Dr. John Jacobsen, a board-certified family practice physician, is the founder and owner of Click Family Healthcare clinics in Kearney and Broken Bow, Nebraska. Dr. Jacobsen, who grew up in Myrna, was an ag banker for more than 10 years before applying to medical school. Coming from a small town, his desire was to practice family medicine in a more rural setting. After finishing his residency, he was in private practice in Geneva, Nebraska for over 10 years, caring for all ages, including pediatric, adolescent, adult, and geriatric patients. In addition, he provided obstetrical services, including cesarean sections, upper and lower endoscopies, in-hospital and in-clinic minor surgical procedures, hospital inpatient care, and emergency room services. He served as the hospital chief of staff, was medical director of a nursing home, and was medical director of the hospital outpatient senior behavioral health program. Dr. Jacobsen then moved to Omaha to become the chief medical officer of a startup primary care center, a role that was administrative in nature. After 3.5 years in that role, the desire to provide direct patient care led him to decide to open Click Family Healthcare. He has been active in family medicine organizations at both the state and national levels, and he credits his wife Janet for their success. They have 2 daughters and 3 grandchildren, the youngest being a few weeks old. He opened Click Family Health in Kearney, Nebraska in 2017 and a second location in Broken Bow, Nebraska in 2020. Welcome to the podcast, Dr. Jacobsen.
Thank you. I'm glad to be with you.
I've been to Kearney, and what I thought was so amazing was that you had gone to medical school with one of my former attendings out in Superior, Dr. Julie Tice. And so what a small world and what a way to celebrate medicine and business and entrepreneurship in Kearney and now Broken Bow.
It's been an adventure. I'll say that, having gone from banking and then to medical school and then into the fee-for-service world where I own my own practice, and then leaving that to become the chief medical officer of a new primary care startup center in Omaha, where we had a $55 million clinic, 6-story, 150,000 square feet, where we wanted to be a one-stop shop. So we had our own pharmacy, lab, all of the imaging you would want. We had, behavioral health and optometry and physical therapy all within our building, just trying to improve the healthcare. And it was mainly of people 55 and older, because we were going after the shared dollars, with the ACOs. And, having done that for 3.5 years and getting really, really burned out, coming back home, even though home is actually 70 miles from Kearney, but coming back to central Nebraska, where it's a different pace, it's a different lifestyle, was really, really good.
Let's delve into that a little bit more, because you're from Myrna originally. So can you please share a little bit about central Nebraska, about where Kearney is in relation to big city centers and where Broken Bow is in relation to those same places?
Well, Myrna and Broken Bow are pretty much geographically in the center of Nebraska. If you were to dissect it north, south, and east, west, we're right at the edge of the Sandhills. So if people don't know what the Sandhills are, that's some of the best country for raising livestock and cattle that there is in the United States. When you go south of Broken Bow towards what we call the Platte River Valley, which kind of is what Interstate 80 runs through, it becomes more farming. Central Nebraska really has a lot to offer. From a tourism standpoint, the cranes migrate through here. We have the geese migrations. Of course, we have Nebraska football, which that's not anything to brag about the last few years. But overall, there's so many things to do. A lot of people think Nebraska is just this desolate desert that you drive across, when really there's a lot to do. And Kearney it's a college town. So it's a university, it's a branch of the University of Nebraska. And so they've got typically 8,000 to 9,000 students. So there's always those things that you can do if you want to, go to college sports or college activities. But central Nebraska is unique in that it's just a little slower lifestyle for most people. Most people are very, very gracious. Most people are very humble, and it makes it fun to be their friend and take care of them when they come to see us in our clinics. Broken Bow specifically is a town of about 4,000 which has kind of gone through a resurgent the last few years. And we actually bought a old practice clinic building that had closed in July of 2016 and renovated it to fit direct primary care. I always laugh. The exam rooms were 7.5 feet by 11. So it was like a glorified closet. So we took 3 rooms and made 2. We opened it up. One thing I don't like coming from the banking industry is barriers. So you walk into a typical family practice clinic, and the first thing you see is this glass wall. And it's like, oh, I know you're sick. Come in. We want to help you, but stay back because we don't want you too close. And so we removed all the barriers that were there. And people who've come into our clinic that used to go to the Broken Bow Clinic can't believe the transformation that we've made. Kearney itself is around 30,000 people. It's, again, in central Nebraska. Kearney's unique in that one, it's a college town, but it two has a lot of small industry, whether it be manufacturing, driven from the ag economy, but the Kearney economy is not directly tied to the ag economy like Broken Bow is. So we get some diversity as far as not just seeing farmers, not just seeing ranchers. We're also seeing people who are working in retail, people who are working in manufacturing, which makes it fun and adds stability to our business.
When you're mentioning direct primary care as a business model, and you've so wonderfully highlighted the points of having value, accessibility, affordability, and having a product that's easy to use, I want to delve into your history and your experience in banking. Can you share about your business background in ag banking and what lessons have you been able to pull from that have made you successful in DPC so far?
Well, I think banking in and of itself was a second career for me, or was a second thought process. I actually started pre-med right out of high school. And I went to college for a semester, and after a semester, I quit because I went home and told my dad I didn't know what I wanted to do, and I just was struggling. So I actually worked for a farmer for a year and a half and drove semi and planted crops and harvested crops. And one of the best lessons I ever got in life was I'd worked for him for about a year, and he was my best friend and my best friend's dad. And I said, gosh, Tyke, I worked for a year. I really think I need a raise. And he went into this story about how he couldn't afford to give me a raise. And the next week drove up in a brand new pickup truck. So I knew right there where I was on the pecking order. And so that really motivated me to go back to school. And I thought, I always wanted to be a farmer, but I didn't marry it, and then I'm not going to inherit it. So what a better way to work with farmers and get into banking? And that's really what I did. I started out in a small bank up in the Sandhills. After about 3.5 years, though, realized that's not what I wanted to do forever. And I had an uncle who was a physician in Broken Bow, and he actually got me connected with the dean of admissions at the University of Nebraska Medical Center. So my wife and I went down and talked to him, and he said, "You've been out of school for 3.5, 4 years. You've got 2 kids at home. There's no way you'd make it in med school." So, just put our head down and kept working in banking. And the town I was living in with my last banking job, we had a city-owned hospital, and they hired a physician and they guaranteed him, I think it was $120,000 a year, but this is back in 1989, 88, 90. So that was really good money. And 3 days short of his contract, he left. And I kept telling my wife that, I'd really love to go back and be a family physician. I'd really love to be in a small town. And she finally, I always tell people, she gave me the ultimatum, either put up or shut up. And so we decided to move. I resigned from the bank effective on Friday. We loaded the U-Haul on Saturday. We unloaded it Sunday, and I started classes at UNK here in Kearney on Monday. And so through that 2-year process, that's what got me then to where I applied and got into med school. But the thing about banking that I think has been so beneficial for me is, one, it taught me the business side of things. DPC is a business. So you need to know the ins and outs, the what's a balance sheet, what's expenses, what's income, those kind of things. 2, I had got up to where when I resigned, I was the second in command of the vice president. So I got some experience managing people, and I was able to attend courses on human resources and management. Also, we were coming off the end of the ag crisis. So I actually had to deal with customers who were financially insolvent, and had to have hard, tough discussions with them about, we may have to sell the farm, or we have to sell equipment or livestock or assets in order to pay your loans back. And that experience helped me, I think, become a better person, being able to see both sides of the business, both the good and the bad of banking, both the good and the bad of people. And when I left banking to apply to med school, a lot of my customers were kind of razzing me. I said, "Well, I've told you should sell your corn above what we've put in the cash flow. if you come see me as a doctor and I tell you, you need to quit smoking, if you don't, you're going to die. So this, there's a correlation. You either go broke or you die. And so it was a blessing in disguise for me to go do something else for 10 years, to learn people skills, to learn the financial skills. When I got out of med school and ended up in Geneva, there were three of us that bought two clinics and merged them together. And I was the financial guy. Another one did the human resources, and another one did supplies and purchasing. So it allowed me to continue the financial side of things and kept me in the loop there. Now, there's a lot of things that I've forgotten about banking, but it's allowed me to be and understand the business side of things.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. What a rich history to bring to your clinic and to bring to your population, because not only did you know how to talk with people in difficult situations, whether it be healthcare or finances, but also the fact that you grew up in Myrna, that you are familiar with Nebraska, that you know the culture of Nebraska too. Can you please share how you came to learn about DPC and how that transformed your plans in life into opening your DPC?
Sure. When I was in the fee-for-service world, my first partner boss that I was with, I was 43, he was 83. And he got me involved with the politics, I guess, of healthcare. So he was a big advocate of the Nebraska Academy of Family Physicians. So I started going through the leadership paths there, got to where I was on different committees, and then I became president in 2014. And that allowed me then to go to a lot of American Academy of Family Physician meetings where I got to hear people from all over the United States, the so-called gurus, talk about healthcare. And then we had a guy actually from Nebraska, Bob Wergen, who was a family physician in Milford, got elected to the board of the American Academy of Family Physicians. And he prompted me to try to get on to the Finance and Insurance Commission for the American Academy. So I sat on that for 4 years, and then I chaired it for a year. And so it allowed me to be exposed to a lot of different ideas. And I was at a meeting, it was, I think, around 2012 when I actually heard Josh Umber and Doug Nunemaker talking about starting a direct primary care clinic or a cash pay clinic where they just got out of residency and they didn't want to work in the Obamacare type work of clinic structure or reimbursement structure. And at the time of that, yeah, that's kind of a cool little niche market. You know, you could move to Wichita, or I could move to Lincoln or Grand Island or Omaha, and I could probably do that. But at that time, I was still had my head in the sand, I guess, about fee for service. And, you know, we've got to do this, we've got to do that. And so that really was my initial exposure. Came about 2014, 2015, 16, somewhere in there. I again heard Josh talk at a meeting, at an AFP meeting, and the storyline kind of changed that, you know, we now have small businesses coming to us, asking us for how can we help you because we're paying so much for insurance or we can't provide a benefit to our employees that it's limiting our growth. And at that time, the bells kind of started to go off in the back of my mind that, hey, this might be something that is growable or expandable. Not that you're going to be able to take care of every person in America, but at least it's no longer a niche market. And so I left Geneva in December 2013. I moved to Omaha. And our whole philosophy in Omaha was we wanted to get part of the ACO shared dollars, savings dollars. So that was our whole structure, and did that for about 3.5 years when I finally, we decided to make the move. In between there, my brother-in-law, who was my best friend, was diagnosed with a funky cancer to where they removed literally half of his skull, and said, you do radiation, you've got a 10 to 15 year life expectancy. And in 16 months, he was dead. And so my wife and I are driving home from the funeral, and I looked at her, I said, all right, honey, where are we going? Because I'd quit my job the end of February of 17 because I was so burned out that I actually didn't work until August. I started doing some locums. But in May, the end of May is really when we decided that, we're going to do direct primary care. We looked at Lincoln, we looked at Kearney, and we looked at Broken Bow. And we ended up landing in Kearney, one, because of the business environment there, with small industry being ag, an ag economy around it. But we also moved there because my youngest daughter lives there, and that's where our grandkids are. So that's really how we ended up there. But the idea that coming from the business background of being able to talk to different people in their language. So I can talk to a farmer about their blood pressure, talking about hydraulics of a tractor. I can talk to people who are in manufacturing based upon my experiences. So it does, I think, make me a better physician because I can build that relationship, which I was able to do in Geneva because I inherited Dr. Ashby's population to where I had mainly 30-minute appointments, but my population was actually 70 and older, the bulk of them too. So that whole background, listening to Josh and Doug. And then when I decided that this is something I wanted to do, I actually went on the trail and I went and talked to shadowed Doug and Josh. I went to, I'm drawing a blank, Ryan Newhoffel. I went to his clinic. I went to Jennifer Heriter's clinic. At that time, I didn't know Vance Lassie's, or I went to his clinic, but I made that loop down and spent 2 days just gathering information of how does this work, the ins and outs of it. I've always felt like I had the business sense to do it. It's just the other things. And, direct primary care is not without stressors. It's just a different kind of stress.
Yeah, absolutely. Dr. Nasser Mohammed put it beautifully. He's never worked so hard in his life, but he loves every day of his work. And it's very different than showing up in a fee-for-service clinic where you are, like you said, you're burned out and burned to a crisp in some cases to the point of quitting.
I always ask my customers, how you doing? Or I ask friends, how you're doing? And I always love it when they say, well, I'm living the dream. Because most of the time when people say that, they're being a little bit facetious. And my immediate response to that question when they say that is, are you living your dream or somebody else's dream?
Yeah.
Because if you're living your dream, it's not a job. You work. I work more hours. Last night, the last 3 nights, we've had our grandkids, and we handed them off to my son-in-law's parents last night. And at 8:00, they called wondering if we forgot to bring over the kids' clothes. It's like, well, no, we're still at the clinic. I was finishing up notes. Yesterday happened to be a day I just really got bombarded. And it's like, oh, really? Well, both of them had only worked 8 to 5 jobs their whole lives.
Yeah.
And medicine's not an 8 to 5 job. People don't get sick between 8 and 5. And that's what I really like about direct primary care is people can text you. As you know, people text you at 8:00 and you take care of it in a heartbeat, instead of them festering and worrying all night or fussing all night. And, my friends who I talked about direct primary care say, oh gosh, I'll be on call 24/7, 365. And it's like, you are, but you aren't, because people know if they call at 5 o'clock on Friday, you're going to take care of it. If they call at Wednesday, you're going to get it taken care of. So they don't wait to the last minute because, gosh, if I go to the doctor or go to the ER, I'm going to drop $1,000 or, whatever that cost is. And that's really what I like about direct primary care. I have one patient that about every 3 months, I'll get a call about 8 o'clock on Friday night. And I'll pick up the phone and say, "Hey, Jacob, what's going on?" He goes, "Nothing. I'm just sitting here with some friends and I just bet them $20 you'd pick up the phone if I called you." And I said, "Okay." So now I started saying, "Okay, we'll drop 10 off at the clinic of that 20." And that's the thing we do. It's not work when you love what you do.
Yeah, it's so true. It's so rewarding. I had a patient call me at 10:30 at night, and this person, they never call for acute issues. And so when I saw their name on my caller ID, I picked up and I was able to go to their house, do an EKG, figure out what was going on, provided this person with reassurance, saved this person a trip to the ER. And within an hour, I was home. And so for the people who are really thinking about, this 24/7, 365, you're so right. And so many people have said that before, that your patients know that they can get a hold of you when they actually need you. And if this goes back to that ease of use in the 4 prongs of that value proposition for DPC that you are mentioning, that when they know and they develop confidence in that you are accessible, and it's very easy to get a hold of you, that frantic state of, what am I going to do? What am I going to do? I got to call last minute. It really, really does go down. So I hope that the people who are in that space of like, hey, this 24/7 is a deal breaker, do reach out to people like yourself, other people who have accessibility after hours, and ask them what it's really like in their communities to serve like that.
And I think it's really funny, when we first opened, we do callbacks, either the next day or either the following day or the next day. And when we first started doing them, people would pick up the phone. I'd say, "Hey, this is Dr. Jake, just want to see how you're feeling." And it's like, "Why are you calling?" And I just want to make sure you're feeling better. I was a little worried that, make sure things are going better. And when my nurse does that, and now if I don't call them or she doesn't call them, it's like, "Well, you didn't call me last time." And I'll just joke, say, "Well, you weren't that sick, so I wasn't worried about you." But people, that again, it's another layer of the relationship. And if I correlate it back to banking, if we could get you, Marielle, to open a checking account in our bank, the next thing we did is we tried to push you to get a savings, and then we tried to loan you money for a car, and then we tried to say, I'd see on the street, say, "Hey, when you and your husband are going to be buying a house, we're here to help finance that house," because we knew the more products you bought from us, the more likely you're going to stay with us. That's the customer service part that most physicians in the fee-for-service world who are employed don't even think about. The last thing when you tell a physician they're a salesman, most of them put their hands and say, "No, I'm not a salesman." We're a salesman every day. We're selling our knowledge. We're selling a diagnosis. We're selling a medicine. We're selling whatever, lifestyle changes, those kind of things. So that's the fun part of being in a direct primary care practice. And you mentioned Amber. When I was in Geneva, Amber actually did a couple months with us. She was a resident.
Wow.
And so she was actually the 3rd clinic in the state to open. I was the 2nd, and Todd Johnson in Lincoln was the 1st. And then you mentioned Dr. Boucher. My daughter, my 38-year-old daughter, our oldest girl, just had a baby last Tuesday. And she called me and said, "Hey, I found this guy that does DPC pediatrics." And he's just like 5 blocks from where I live. I said, "Go for it." I mean, she has got a job that she has pretty decent insurance, but they're going the DPC route just because of what she's seen our customers get that benefit. And they've joined his practice.
It's amazing. So amazing. And he's actually going to be on the podcast in a few weeks. So that's awesome.
I need to get connected with him just to introduce myself.
Absolutely. Absolutely. Grow that network in Nebraska. I love it. When you made the decision that you're going to be in Kearney, what was the planning process like in terms of starting to plan to actually opening and seeing your first patient? In terms of your building, how did you choose it? And how did you get your staff lined up prior to opening? Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
So when we decided to make the move, again, our youngest daughter was living here, so my wife and I made multiple trips to Kearney looking to rent space. And we actually struggled to find what we felt would be a small enough space, but in a good, and not, I don't want to say good enough location, but in a location that I felt was appropriate for healthcare. And we finally ended up putting an offer on a Saturday morning on a building that was $625,000. I'll never forget the offer. Because I told the bank, I can moonlight forever to pay for this. But that night I was going at halftime of the first Nebraska football game in 1997. I was going to the grocery store for something for my grandkids. And I drove by this building that had a sign for rent. And so I pulled in and looked, and it was wide open. And so I called my realtor and said, "Hey, why haven't we looked at this building?" And she goes, "Well, I don't know." So after the game at 10 o'clock, we've got our eyes against the window. We got the headlights shining in. And I actually withdrew my offer on the building. Called the people that owned this, sat down and met with them the next week, and actually designed our clinic the way we wanted, because this building was pretty much wide open. Mm-hmm. So we laid our building out, and very fortunate. We just pay a per square foot fee rent, but it includes utilities. There's no triple net because they built it out. They own the building. So I felt like when I didn't want a triple net to be stuck in there, and they were willing to negotiate that with us. So that's how we got into Kearney. And we actually, when we started, we had a young lady, a friend of mine. Actually, he used to be my boss in banking. His daughter went to massage school. She was going to do yoga. So we actually designed space for her in our practice as well, because I wanted to use her if I had somebody with chronic pain. Mm-hmm. Let's go get a massage, or let's go to physical therapy, because I'm not a narcotic person at all. So we started out, and that's how we worked. When we first opened, it was just my wife and I. We were open about 2 months when I finally, we opened November 15th, November 17th. By the January 1, we had like 85 people signed up. And then we were continuing to grow. So I went and hired an RN who actually came to me from the psych world. So in Kearney, there's Richard Young Hospital, which is a psychiatric hospital. And so she joined us, and she allowed us then that I could leave the clinic and she could answer the phone, and I could go out and start knocking on doors and meeting with business people and promoting what we did. When we went to Broken Bow, I had no intention of expanding. Absolutely none. I was at a bank open house here in Kearney, and they have a branch in Broken Bow. They have a branch actually down by Fullerton, where I used to live. And one of the girls was on the economic development board. She goes, "Oh, you should come look at this building we've got. It's the old Dr. Brooks' old clinic." And I said, I'm by myself. I'm getting busy. I don't really know. And so I kept telling her no, but then we went and looked. About 4 weeks later, we drove up and looked at the building. And I just told them, no, I'm not ready to expand. And then about 2, 3 months later, she called me again and said, look, economic development owns the building. We're tired of paying rent. We're tired of paying the taxes. We know it needs some work. Just come look at it and make us an offer. We've had a lot of people look, but nobody can figure out how to modify the building for their particular business. So my wife and I went back up and we looked again and just kind of had this epiphany that there's a demand here. There's a need here. We can get somebody to come join us somehow, some way, just kind of prayed that God would lead us down that path and made an offer and they accepted it, and everybody thinks that I got a great deal on the building, but then I follow that up with the first thing I did was spent $33,000 on 4 new furnaces and air conditioners. So it was a good deal. The bones of the building are really good. It's a nice brick building, but it had sat empty for 4 years. It hadn't had a lot of done. It was built in 1978, 1979. So furnaces, air conditioners, all those things. But we were able to modify it to where we have our space, and then we've renovated one other hallway to where the economic development actually now rents space from us. And then we have a mental health clinic that rents an office from us. So cool. We have that right in the building that we can refer to them. And they've been very helpful with our customers, getting them in a timely manner.
That's awesome.
So I still have a hallway to renovate and rent out, but the good thing is it's cash flowing, the rent's paying all the bills. And so we're doing fine.
I want to take a step back because you mentioned you opened in November. By January, you had about 80 patients. With you being the second DPC and the first one being, all the way in Lincoln, how did you generate your patient base to get those 80 so quickly?
Well, we started out, we were on TV, on the local radio station or new TV. We did some radio things, and that really is what jump started us. After that initial rush, because it was the end of, open enrollment's open, people are losing their insurance or whatever, things slowed down a little bit. So we saw this kind of peak and then things kind of tapered off. We've really focused on social media. I hired a college kid to do a social media for us, and she did a pretty good job, but then she got other things going on in her life. And we now, since we've opened our second clinic, we are now actually working with a local company called Control Yours. That's what they do. They're an internet marketing company. They're managing our Facebook. They're running all of our ads, and our nurse practitioner, she does quite a few posts, but they're the ones managing all that for us. So we're really trying to drive people to us. We're also in the process of modifying our website. We opened our website. When we opened, I had my nephew out of Minneapolis who does marketing and brand development. He helped us develop our brand, and he did our webpage for us. He did our initial marketing for us. And really, when you start to build a business, you really want a website that looks pretty, that looks nice, it explains things well. But when you get to the point where you want to really focus on growth, you need to modify that webpage to where now it's driving people to sales. Mm-hmm. So we have a new landing page on our website. And so, you can click on something in Facebook and it takes you to our landing page. And then we'll be in the process of renovating the backside of our website with all of our products. Now that Dr. Peterson's on, we're doing PRF, PRP, we're doing some microneedling, along with Dr. Peterson, who will be adding obesity medicine and some ultrasound guided procedures.
Before we talk about Dr. Peterson, because he just joined your practice last month. You said 3 weeks ago before we started the recording, which is so exciting because you said, you put that out into the universe, like somebody will join us somehow, some way, as this movement continues like wildfire, people are joining and somebody join your practice. So let me ask you though, because you dropped some great pearls with regards to how you negotiated out the triple net. And so I wonder, just with your history in banking and with your history of getting 2 buildings under your belt and having the space be used for not only your practice, but other uses as well, what are some tips that you can give to people who are contemplating Do I buy a building? Do I rent a building? And at what point do you suggest people start looking before they have patience, or doing a little bit of funding before they jump into something like a 3-year lease?
Well, everybody's situation is different. Like I said, I was 57, so I had some financial resources that a lot of people don't have. When they're just coming out of residency or been out 3 or 4 years, my student loans were all paid back a number of years ago. I think initially renting a space is always the best because that's a short-term commitment. Even if it's 3 years, that's still a short-term commitment versus buying space. With our economy the way it is right now, with inflation the way it is right now, I mean, if you can lock in a 3-year, I mean, we actually did a 5-year just because I knew I wasn't going anywhere. I'm 57. This is what I'm doing. Being a banker, I always look at the negative side of things because that's what I always had to do. But I never had a doubt that direct primary care would work. And so we went out, we signed a 5-year lease, going all in that regards. But if I was younger and didn't have the financial resources, there's an old adage, why buy what you can rent or why rent what you can steal? So I would definitely tell people to rent initially. Now, if you can walk in and you can negotiate with a private land or building owner that, is maybe older and wants to supplement their retirement by maybe doing a 10-year or 15-year contract, then look at the option of doing that as well. As far as renting space, like with our clinic, with the massage therapist that did yoga, she actually just sub-rented lease from us. So I rented the space. We had a sublease with her. We've had 2 mental health providers who've come into our clinic. I've just paid them a per visit, or they paid me. So, the first guy, I charged him $5 an hour just because I didn't want to make any money on them. I just wanted them to take care of our customers. So there's lots of options that you can do. If the one thing that I think people really have to understand is with any kind of ancillary service you're going to provide, you want to make sure you keep an arm's length because you want to make sure that people don't perceive that they're under your care when they're seeing this other person, that they are separate from you. I think there's some medical liability issues if you give that perception. So we have a deal with a physical therapist here in town. They do the first visit free, and then they charge $45 a visit cash after that. That's a third-party transaction between my customer and them. We have nothing to do with that. When we refer to chiropractic, we refer to the dentist, we refer to the optometrist. Those are all arm's length transactions. So people a lot of times try to, I think, overthink things. And just like DPC, when you're talking to customers about, no, this is really simple, that's what you want to do when you're thinking about opening your business. Less is often more. So when we opened, I went and I ordered way too many pharmaceuticals from Amanda. At the end of the first year, it's like, oh, I'm throwing this bottle of 500 lisinopril away, instead of just buying it as I added those customers, which is what we do now. You don't need to have everything that you had in your fee-for-service world because you're not going to have 2,500 people out of the gate. You don't have 3 other partners. So you got, 15,000 people you're serving. You don't need 10 or an $8 or $10,000 EKG. You don't need a procedure room that's set up like the Taj Mahal. I mean, I bought things off eBay. I bought things off of Amazon, different, just medical instruments that I'm not going to use a lot. I did buy an autoclave from a business that closed. I bought a used EKG from him that just crapped out on me last week. So I just ordered a new EKG for both of our clinics. But buying things, you don't have to buy new, and 2, buy them as you need them. Mm-hmm. Telling somebody, hey, I'm sorry, I don't have an EKG, but I can get you one at the local hospital for $50. That's still way cheaper than if they go to the local hospital on their own or they go to the ER. And so I think people need to focus on less is more when you're first starting out.
But keeping the overhead low is so important, especially as you're evaluating your financials, especially if you do have school loans, et cetera, starting DPC.
And I say that with tongue in cheek because the advice I give is not the advice I took. So when we opened our clinic in Kearney, it was a brand new facility, top to bottom. It was an empty space, brand new. And my wife said, you don't want to buy old used equipment for exam tables. You don't want to buy, you can only make that first impression once. And what we're trying to do is show people healthcare can be different. So our lobby does not look like a medical office. It looks more like a lounge. You walk in, there's a oak buffet, there's big chairs. But when you go back in the procedure room, I didn't buy what I call box tables. I bought procedure chairs. So I spent a lot of money on those. I bought procedure carts because I don't like things hanging on the wall. So I didn't want otoscope, ophthalmoscopes hanging on the wall. So we bought procedure carts, that were $1,800 a piece. When I opened Broken Bow, I went and bought $400 Craftsman toolboxes. They do the same thing, but they were $1,400 cheaper. So we went through a local company here where we bought our cabinets. Broken Bow, we went to Menards and bought our cabinets. So learning, and not that that's not okay. It's just that our cabinets in Broken Bow look really nice, but they were $3,500 versus $28,000.
Yeah.
And so those are the things that people just need to keep in mind is you can buy things that are really nice, but you don't have to spend huge amount of dollars to get them. And so don't be afraid to shop around. It's no different. I tell my wife all the time, we're no different than our customers when we tell them, okay, you're a cash pay customer. There's nothing that says we can't go negotiate when we're buying something for our clinic. And so that's what we do. I mean, my wife's a great negotiator. She makes me, she makes a salesman cry. I know we're going to get a good deal.
High five to your wife for that, because that's a great skill to have.
I tell people all the time, sometimes I don't show her, but if it wasn't for her, I wouldn't be here. Yeah. Because when I left banking, she worked 2 jobs while I went to undergrad. That way I could be home for our girls who were, 4th grade and 1st grade when I left the bank. When I started med school, they were 7th grade and 4th grade. So she's the one that allowed me to do and follow my dream. And she's been the one. You want to talk to somebody about DPC? She can talk to you about DPC inside and out, frontwards and backwards. She understands it and she loves it as much as I do.
Awesome.
And we've been really fortunate that the staff that we've hired. So our second nurse, Chris, our first nurse, she ended up moving away. We hired a lady who actually came to us from home health. And she had called one day, and it was really a weird deal. We're looking for a nurse, and she had called one day about one of our patients who was in their home health. And Janet was talking to her about, well, do you know what we do? Well, no. And by the end of the conversation, she goes, are you guys looking to hire somebody? And Janet said, yeah. She goes, well, I'm kind of thinking about getting out of home health. And well, come see us. The next week she comes in. We loved her, offered her a position. So she came from surgery and then home health. So her learning curve in clinical medicine has been steep because she never was exposed to that. But she's been with us now 3 years and she does a fantastic job.
Wonderful. And you alluded to the fact that Dr. Peterson has joined your practice, and then you also have Ann Lano, who is a nurse practitioner. So with the addition of those two to your practice, how do you guys arrange coverage for the 2 clinics? So
initially, in the spring of 2021, Ann was in nurse practitioner school. So she had called up in the previous summer and wondered if I would mentor her so she could do her last semester of her training with us as a student. And so I did that, and I told her I'm doing it reluctantly, but I'm also doing it because your husband and you are customers of ours. Mm-hmm. So her husband, they have the company that we're doing the internet marketing through. They had been customers of ours for a couple of years. And so she understood direct primary care. So then she came and was a student with us. And then about halfway through the spring, and when we opened in Broken Bow, we'd actually hired another nurse practitioner, but our numbers just didn't take off in Broken Bow that I could justify her salary. So I had to cut her loose. But when Ann came on, and then it's about March, she said, well, UNMC has a residency program that I would really like to do, that I would be with you for the next year. The caveat or the good part is they'll pay half my salary. It's like, oh, well, that sounds like a win-win. I can cut your salary in half, but train you the way you need to be trained to do family medicine. And so she came on board and has been with us full-time since July. And then she'll be, at the end of June, she'll be done with her residency, and then she'll stay with us. And then last fall, Jacob reached out to me. Jacob's been out of residency about 3.5 years. He started actually in the fall of 2018 in a town about 40 miles away, Holdridge. You might be familiar with that, with your Superior ties. And he had gone out and talked to some people on his own, Vance Lassie, for instance. And really, when he came to me, it was like, well, what do you think about if I would be interested in joining you? It's like, I'm willing. I'm 61. I'm starting to think about a transition plan out of direct primary care because I want to retire someday. And he said, well, I went and talked. Well, one of the questions he asked me was, well, if you had the opportunity to open a clinic or join somebody, what would you have done? And I said, I absolutely would have joined somebody. I wouldn't have gone through and expended all the energy that we've expended the last 4 years to grow this, to get it where we are today. And so he goes, well, that's what Vance Lassie told me. So that was kind of the impetus. And then, we met with him and his wife. We took him out for dinner. We met with Jacob a couple other times. And the beauty of Jacob is he understands it. He gets it. Absolutely. So he's got a wife. She's actually a family physician as well. She's a Creighton grad, but Jacob already has been doing some moonlighting. So he has a locums gig already set up that he's going to be doing here for the next 4, 5, 6 months. And hopefully, he's grown enough that he doesn't have to do that. But a lot of times when you talk to physicians about direct primary care and you say, well, you may have to do locums until you get your numbers up, that can be a turnoff for a lot of people. But Jacob embraced that and said, oh yeah, I've already got this lined up. I've been doing it 1 weekend a month, and I would continue to do that. And it's like, okay, you understand what it's going to take. He's a small town kid. He grew up by Atkinson, which is a ranching, farming community up in the northern part of the state. So the work ethic is there.
Yeah.
So it's been just a really good relationship. He's at this point, he's a 1099 employee. So we will just pay him a percent of what he brings in, and then the rest of it will go to cover his overhead. But again, I'm looking to the future. So I'm not really too hard on him when it comes to what we're going to charge him for, what that percent is, because I want him to stay. And I've told him, if you feel like at some point you want to leave, just ask me and I'll step out and you can take this over, because we need more direct primary care physicians in Kearney. And we actually have a physician that just opened one, a female physician. I've been told there's a nurse practitioner that's just opened a direct primary type clinic. So people are getting into it and growing it. But Jacob, we're just absolutely floored that he decided to join us, because one, he's got great skills. He actually did the primary care program at the university where he did internal medicine and family medicine. Wow. So he did a lot of internal medicine, but he's boarded in family medicine. He recently got boarded in obesity medicine. So, and we've seen since he's opened, this past week, I looked at the schedule for this next week. He already has 5 or 6 obesity appointments set up just to talk to people about what he does. Mm-hmm. And so I don't think it's going to take us long to get him busy doing that. But he also does primary care. So, he can do the toddler up to the 80-year-old that we have in our clinic.
Yeah. Wonderful. And let me ask you, because going back to the fact that he's a 1099, what models, especially from your business background, would you say would be models to think about if a physician is looking to bring on another physician to their practice in addition to a 1099?
Well, I think it really depends on the number of patients you have in your panel. I mean, if you've got 1,000 people in your panel, you've got cushion there that you could say, okay, I'll guarantee you 4,000, 5,000, 6,000 a month, and then we'll take a percent of what you bring in, and I will pay you that. And I think that's more of the Josh Umber model. Or I think actually Josh, they just start them out at 220 or something a year. But I know there are some other physicians who've done, we'll give you a base and then a percent above that. With Ann coming on, with Jacob joining us, it's like, I think for me and you, I think the most fair thing is let's just do a 1099.
Mm-hmm.
But it's like stepping out of the fee-for-service world. The direct primary care world allows you to do anything.
Mm-hmm.
So think outside the box. And you'll be surprised if you ask a young physician, how do you think you ought to be paid? They probably have 2 or 3 ideas that they've already thought about. So what a way to build a relationship is let them tell you what they think.
Yeah.
Just like we ask our patients what they think. But I think you're either going to pay them a flat salary, you're going to pay them a smaller guarantee plus a percent, or you do a 1099. Those are the 3 ways I would look at the initial thought process of adding someone.
Mm-hmm.
Now with Ann, she's an employee. So she's just employed by we'll look at an hourly rate, and then we'll figure that out for a salary. And that's what her base will be.
Gotcha. Now, you mentioned how Jacob's bringing a bunch of new things to the clinic. You mentioned that he is board certified in obesity medicine, but can you tell us about procedures that you have been offering and that now you are going to be offering with Jacob joining your practice?
Sure. We do. I was been trained that I do vasectomies. If there's something I can cut off, I'll cut it off. I'll biopsy anything unless it's on your face. So we've been offering a pretty wide variety of joint injections. We're now doing PRP and PRF. We've had a lady that has had this wound that I am amazed at how PRF is healing that. But one of the things, and Jacob does those things too. One of the things he has some experiences with ultrasound. So when he joined us, we went out and bought an ultrasound, not a butterfly. We went out and spent 25 grand on an ultrasound machine, but it allows him to do ultrasound guided carpal tunnel surgery. So he works with a company that with their device, he makes a 4 millimeter incision, puts the device in under, first the criteria of what do you have carpal tunnel, but then the procedure, average recovery back to work is 1.6 days. He's done over 70 of them so far. The device itself is fairly pricey at about $1,000. So we're going to price that probably at 2 for one and 3 for both sides. But that's still 40 to 50% cheaper than going to the local or local outpatient surgical center. He does vasectomies, he does INDs, all those kind of things as well. But the ultrasound is one thing that he feels comfortable, even like he looked for a young girl that Ann saw that couldn't find the strings for IUD. So where's the IUD? So he did an ultrasound of her pelvis. Didn't do a transvag, but did an ultrasound of her pelvis. You could see that the IUD was in her uterus. So we at least know it hasn't migrated outside of her uterus. So there are things like that he's had enough experience and had training on that, we're not going to do it and read it in-house, but he can do it and we can make the decision, okay, do we need to have you go to the hospital and do more screening? And, we're lucky here in Kearney. Have you ever heard of MD Save?
Yes.
So we're lucky that both hospitals here, but CHI was kind of the leader in that. And so, we use MD Save a lot for all of our imaging, whether it be ultrasound, mammograms, CTs or MRIs. And so we can use the ultrasound as a screening tool before we make that decision. Yeah, we need to send you down to the hospital and get a definitive done. That's what we think is going on. But, in Kearney with 2 hospital systems, when it comes to medical malpractice, you have to look at what's the standard of care in your community. And unfortunately, that would be the standard of care is to send them to the hospital. But I'm thinking about it, and Jacob's thinking about actually getting a VPN set up with a radiology company in Lincoln that we could capture those images, send them down. But then you really, what images do they want? From a sonographer's standpoint, are we doing the right images that
Sure.
the radiologist wants? So that's kind of up in the air. But
Gotcha.
those are two of the really exciting things on top of obesity medicine that I think we're going to add people to our practice that it's a service they're not getting anywhere else for
Absolutely.
for a price that they can afford.
Mm-hmm.
They can go get it at the couple of local fee for service clinics, but our labs are $44. The local clinics are $250 to $600. So
when a patient hears that, or when a potential patient hears what the cost of a CBC is if you do it with transparent wholesale pricing versus what they got billed, with their surprise bill a year after they actually had the labs done, they're just like, what? Wait, what? Well, why would I use my insurance? And they're blown away. So yeah, I definitely would say that.
I had a lady yesterday that we do some hormone testing. I use Amber some to help me with some of that. And, her saliva hormone testing was $150. She's been going to a nurse practitioner that her blood test has been costing $350 to $400. I said, we really need to get a baseline, CBC, CMP, lipid panel, TSH, free T4, and I do a vitamin D on everybody because over 70% of Nebraska is vitamin D deficient. And I said, it's $44. We charge $10 to draw your blood, and you pay essentially what I pay for the lab test. She has her labs that she had done in November at her local clinic in Holdridge, which is where the clinic Jacob used to be at. She goes, I paid $1,200 cash.
Oh my gosh.
For these labs. And I said, well, welcome to our world.
Yeah. Welcome to DPC. Absolutely.
Exactly.
Oh man. Now I want to take a step back in that you were mentioning how involved with the AAFP you were and with the Nebraska Family Medicine Organization. And so I want to ask, do you see DPC really getting a national spotlight as more and more physicians are really wanting a different way and a better way to do medicine?
I wish I could say yes. When I was doing my term on the Insurance and Finance Commission, it was and it continues to be all about payment reform, MACRA, MIPS, all these little acronyms. And as I was finishing my time on the AFP Finance Insurance Commission, I really started thinking about where family medicine is at today. And I actually asked a couple of the executive leaders of the AFP, do you feel like the AFP as an organization has put us where we are today? Because you haven't really helped us from a physician burnout. They've started a program of physician wellness or whatever. That's a way to make money for them. But I do not feel like they have. I think they're the ones that have kind of let us down. They're the ones that have bowed to the insurance companies and said, oh yeah, we'll do this. They're the ones that have bowed to Medicare, saying, oh, well, yeah, we want this reform in payment. And they argue, well, that's the best option we had at the time. Well, no, the best option is say, you know what? We have 110,000 members. They're going to quit taking care of Medicare people. So we need to change the way the system is. We need to break the system. We need to start from scratch. The other thing that I think people don't realize is when you start talking about the amount of money that follows fee for service. Two of the two biggest lobbies in Washington, D.C., the Hospital Association and Big Pharma. So it's hard to get a senator or a congressman to think outside the box when they're getting money pushed in their back pocket from a healthcare organization like a hospital. If you're familiar with MD Save, if you walk in and use your insurance card in Kearney, it's going to cost you $2,200 to $2,600 to get an MRI without contrast. But if you buy it up front, it's $436.
Yeah.
Well, to me, that's a travesty. There's 75% fluff in the cost if you have insurance. And why are we doing that? Or why is that an option? And so I would love to say yes, but unfortunately, I don't think so. Now, I backed out a little bit of the AFP. I was on the board of the NAFP. I was an alternate delegate to the AFP, but I resigned from that 2.5, 3 years ago, because when I went to the last Congress of Delegates for the AFP, there was nothing there about direct primary care. It was all things that I didn't even deal with. And I went back to the leadership of the NAFP and said, you really need to get somebody here that lives that world. I don't live in that world anymore. Now, I feel your pain, but I don't live in that world of having to worry about payment reform and how am I going to get reimbursed. And so short answer is I wish, but I don't think we're ever going to get that push. And that's where I think the DPC Alliance has been good. I mean, the AFP has thrown a little bit of money, out there and has helped with what's not the nuts and bolts. Is nuts and bolts?
DPC Summit.
So, I mean, they have helped some, and I don't want to say that they haven't, but just, I don't think we'll ever get their full support.
With that said, as this movement clearly is, growing, whether or not the larger organizations support the movement with money, with visibility, et cetera, what are words of encouragement that you have for people who are really on that cusp of, hey, should I do this or not? Because you made that decision even at a later age than most people.
Well, I think the first question is, are you living your dream? And that's the sad part is people who go into family medicine don't go into family medicine to get rich. We go into family medicine to take care of people, to build relationships, and feel like we're doing something worthwhile. People who are burnout, when I got burnout, I wasn't helping anybody. I wasn't helping myself. I wasn't helping our customers. I wasn't helping my relationship with my wife. So I think that's the first thing is, are you living your dream? If not, then we all have to look and make decisions. It doesn't matter if you want to lose weight, you want to quit smoking, you drink too much, you want to make a change in your life. You've got to look at the pros and the cons. And personally, I'm a list writer. So this is the problem. Here's the pros. Here's the cons of all my options. The explosion that we've seen in the DPC, I think, is because more people are getting more burnout, but are also building relationships with people who are in DPC, physicians who are actually practicing and hearing that, hey, this can work, that it's not gloom and doom. It's not on being on call 24/7, 365, that you can set boundaries. You can do what you want to do. The old adage where you always hear at DPC meetings is, you've seen one DPC meeting, you've seen one family practice clinic, fee for service, you've seen every family practice clinic, fee for service. And I truly believe that that's true. I remember in the fall of 97, I went to a meeting in Florida. Amber and I went to that something foundation, but it was a DPC meeting. And the first night, there were like 380 clinics represented. And we hadn't even opened yet. There were 60 or 80 of us that were just looking. And I remember calling my wife and saying, it's the first medical meeting I've ever been at where everybody's happy. There's nobody complaining about their administrator. There's nobody complaining about the hospital. There's nobody complaining about fee for service or Medicare reimbursement or blah, da, 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 da. Nobody complaining that they got disgruntled employees, because you only typically have one or two employees. And if you don't like them, get rid of them and get somebody in there you like, And so I can still remember telling her, everybody's happy. And that's the juxt of it, is that do what you want to be happy, but realize that direct primary care has different stressors. There are, I remember when we first opened, we would sign up 10 people in a week, and then we wouldn't sign anybody up for 2 weeks. It's like, oh my God, we're good, we're golden. And then it's like, oh, we're going to go broke. And then we're golden. And then we're going to go broke. And so, when you look at all the financial charts, it's always a straight line. It actually should be a zigzag line, going up or going down, because you don't add people in a linear fashion. You add them in fits and starts. And the big thing is, one, believe in yourself. Mm-hmm. Two, you have to have the support of your partner, whoever that is. But three, are you living your dream? And if you're not, it's time to make a change anyway. And going from one healthcare system to another healthcare system, unfortunately, it's not going to change how you feel or how you practice medicine.
Well said. Well said. Thank you so much, Dr. Jacobsen, for joining us today.
I'm glad to be here. I love what I do. I love direct primary care. I love what you're doing, getting everybody's stories out. When I drive to Broken Bow, I usually have headphones on and I'm listening to your podcast. Just because everybody has such a unique story, and if you listen to all of your episodes, there is such a diversity in what people are doing and how they're doing it, from your type of practice to, I'm more of a traditional family medicine practice, to somebody who's focusing more on women's health, to somebody who's really focusing more on internal medicine as an adult population. So follow your dream. If you're not living your dream, look in the mirror. And the hardest part is look in the mirror and being honest with yourself and saying, I need to make a change. If an old fat guy from central Nebraska at age 57 can do this and be successful, because right now we're about 850 customers in a little over 4 years, anybody can do it, especially if you're young and you've got more energy than me. Go for it. Live your dream.
Next week, look forward to hearing from Dr. Belén Amat of Direct Primary Care of West Michigan and Grand Rapids, Michigan. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC, check out dpcnews.com. Until next week, this is Marielle Concepcion.